Hi, good afternoon, everyone. We're starting just a few minutes early to let everyone come in from the waiting room. We have about 300 people um, who registered, not all of whom will be here with us today. Some people will be waiting for the recording. This will be recorded, and you will get a link to it within 48 hours. What I am going to do now while people are coming in is I'm going to put up a poll that we have. It's actually a pre-test and would ask that you complete this. Don't worry about getting the questions correct. Just answer them to the best of your ability. If you don't know the answer to one, just, make your best guess. We're going to repeat this at the end. This is for our funder, so that they know that hopefully, I'm the presenter today. I'm Catherine Piers with the NTG, by the way. Um, so that hopefully when we are done in an hour, they will know that I was able to impart at least some pieces of information to you that you maybe didn't know before. So I'm going to launch this pre-test. Please, it's all anonymous. We don't know how you score on it. So don't worry about that at all. And you can just go through the questions and answer them. There are 5 questions. It won't take you long. And again, just do your best. And if you don't know the answer, don't worry about it. So again, people are coming on. Welcome. I'm Catherine Piers with the NTG. We started a few minutes early to let people come in from the waiting room and do the pre-test that our funder has requested that we uh, do. And so we're going to give a few minutes for that. So if you're just coming on, don't be shy. If you'll, just answer the questions in the pre-test to the best of your ability. We don't know who you are or what you answered, so don't worry about, any of those sorts of things. It's anonymous. You just go through the questions and it'll only take a minute. There are only 5 questions. And when we get right to the top of the hour in a couple minutes, I have a couple of housekeeping notes for you, and then we'll get right underway. Welcome if you're just coming on. Again, if you could answer the questions that you see on the screen, it says pre-test. We ought to find a word other than test. Don't anybody get test anxiety by any stretch of the imagination. We expect you are not going to know the answer to all of these. That's the point. We're going to give you the exact same questions at the very end of the webinar. And hopefully, those questions that you weren't sure of or didn't have any idea about what the answer was in the pretest, you will have those uh, answers more at hand when we get to the post test at the very end. But again, um, our funder is requesting that we do this as evidence of learning and that their money was well spent for the webinar series. So you would be doing us a big favor by just taking a couple minutes to answer those questions now and then again at the end. Again, more people coming on. I know I keep repeating myself, those of you that came on early, but we have people coming in every couple of minutes here. There's a pre-test on the screen. Don't get test anxiety. Um, we don't know who you are. It's completely anonymous. Our funder is asking for, some data on the success of these webinars. So we're going to give you the exact same questions at the very end of the webinar. And those questions you weren't sure of in the very beginning, you'll have a chance to see again at the end. And I suspect you will know the answers to them at the end if you don't know them now. So again, just answer.
Catherine, I
Yep.
think you may have to re-put the pretest. The number of people have said their pretest went away, one after another. So
Oh, okay. Let me see. Don't know why. Okay, we'll try it again. Don't know why, unless maybe, I don't know.
it's back
We don't,
up.
okay, we don't usually do it this way. So maybe I spoke too soon when I assured people at the beginning that this was going to work the way it was supposed to. So yes, so please, start working on the pretest. We'll start in I'll give you just a second and then I'll start with the housekeeping. While I'm doing the housekeeping here, please just feel free to go ahead and keep working on the test. And again, if you've just come on, we're going to repeat the test at the end. Don't get test anxiety. We don't know how you've answered or who you are. This is for our funder. And so just take your best guess at answering those questions. And then we'll repeat it at the end of the webinar. It will help our funder and sponsor of this know that the information was worthwhile and that we were able to impart some new information to you, hopefully. So we would greatly appreciate you doing that. While you are doing that, a couple of housekeeping things. Everyone is muted by default. Oh, let me introduce myself first. I'm Catherine Piers. I'm Chief Operating Officer for the National Task Group on Intellectual Disabilities and Dementia Practices, and I'm actually a presenter today as well. And with me are Dr. Kathleen Bishop and Phyllis Amaral from OPICA. I'm going to turn it over to them in just a second. If you have questions at any point during the presentation, please feel free to put them in the Q&A box as they pop into your head. Don't feel the need to hold your question till the end. We would prefer that when you think of something, or if I say something that you're not clear about or confuses you, or maybe reminds you of a situation you've run into with someone you work with, don't hold back. Put them in the Q&A box whenever they pop into your head, and we will be monitoring those. We hope we'll have time for answers to any questions you have at the end. If for any reason we do not, I will take all the questions that you have submitted, answer them offline, and send the answers out in a follow-up email. In addition, in that follow-up email, you are going to get a link to the recording of this session. And my commitment is to get it out to you within 48 hours. A little bit more challenging this week because I'm traveling, but it will be done. So with that, Kathy, I am going to turn it over to you.
Thank you. And I'm Kathy Bishop. I am a lifelong or adult lifelong gerontologist with a specialty with aging with developmental disabilities. I am also a board member of the National Task Group on ID and Dementia Practices, who are working in collaboration with OPICA and especially with Phyllis, who we've been working with for a couple of years now. Doesn't seem that long, but a couple of years on this particular grant, and had worked with, believe it was 2015 when we first worked together. So we've been working together for a long time. In the capacity of NTG, I have worked with organizations and colleagues across the country and some internationally as well, and organizing activities like this. It is a pleasure to be here today for our very first one, the launch of the series, which is one of a kind, focusing solely on adult day programs and aging and dementia in adults with IDD. For people who are in adult programming in the general community, and also for people in the IDD community who participate in day program activities. I look forward to this presentation as much as today, and I want to turn it over to Phyllis Amaral, who will give a brief introduction on OPICA and the grant as well.
Hello, everyone, and thank you so much for being a part of our very first webinar, specifically for those of us who work in adult day programs. I'd like to take just a moment to thank NTG for their enormous contribution that they've made to contribute to this webinar, and they'll continue to make contributions for the webinar and then a toolkit that we'll be providing as well as the grant goes on. I'd like to thank the Administration for Community Living for supporting this webinar series through a grant made to OPICA Adult Days Program and Counseling Center, which is in Los Angeles, California. Finally, I'd like to say that I'm going to put my email in the chat. And the reason for that is this is conceived as a 10 series webinar. And we have plenty of ideas of what we'd like to communicate and information and speakers and whatnot, but we also want to be responsive to you. So if there's a topic that you think really has gotten short shrift in the past, or something that we really need to be discussing around providing adult day services to people with dementia and intellectual or developmental disabilities, please send your suggestions along. We're happy to hear them. We'd love to consider them, and we appreciate any input that you can give us. And now, because we want you to have as much time as possible with Catherine, I'd love to introduce Catherine Piers again as our speaker today. To take a moment to thank her for being with us. She has a wealth of knowledge, and she's a great support to those of us trying to create supportive services for individuals with dementia and intellectual developmental disabilities. So Catherine, thank you so much for being with us, and take it away, please.
Thank you. And with that, I am going to go ahead and end the poll. We had a pretty good response. So I am going to end the poll. And I will, let me just do, whoops. Did my screen change on your end? Or are you still seeing my, hold on, I can, okay, you're still seeing it correctly. All right. All right. Okay, sorry. Get my little thing out of the way here. Trying to get, I've got so many windows open on my laptop, it's getting a little difficult to tell what's what. So, thank you very much. I'm honored to be the lead-off presenter in this wonderful series. I'm going to be giving you kind of an overview today of dementia in adults with IDD. I will just tell you very, very quickly about myself. I've been involved in the field of dementia for, oh gosh, over 40 years now, I guess. Started out in the aging network, and was a family caregiver initially. That's actually how I got involved in this field. My father was diagnosed with Alzheimer's disease when he was only 56 years old back in 1981. And my mother and I took care of him at home for 10 years. And that was what started my interest in this field. I was managing a medical practice at the time, but through our caring for him, really realized what a tough road this is for families, and particularly around the behavioral issues that arise with dementia. And long story short, I wound up working for the Alzheimer's Association for almost 20 years. In 2011, started my own training and consulting company. And for probably close to the last 10, 12, 13 years now, have been primarily working with the ID population. And absolutely love it. And have been with the National Task Group since about 2011, I guess. So with that, the typical disclaimer, don't disregard any professional medical advice or delay seeking treatment. What's going to be presented in this webinar is educational in nature and is provided as general information. So kind of the standard disclaimer for you all. And, we have to always write the objectives for these sorts of things. So we're going to talk a little bit about how dementia maybe presents differently in aging adults with ID than it does in people in the general or neurotypical, as it's sometimes called, population. We're going to talk about some underlying medical conditions that could be mistaken for the onset, there's a typo, of an irreversible dementia. And then talk about the steps that are involved in how to get what I'll do air quotes, a proper diagnostic process for dementia, which sadly is something that rarely gets done in this population. Although I also have to say that for my years working in the aging network, it doesn't always get done in the general population either. So if you have family members with ID, this is definitely relevant, but even if you have family members who don't have ID, I think you're going to get probably take away some things that you might find useful as well for your family members. So let's kind of just get on the same page here to make sure we're all starting off at the same place. One of the most common misconceptions that I run into when I talk about ID and dementia is the notion that that word dementia, when we say it, I think people oftentimes, the first thing that pops into their head is they think Alzheimer's disease. And there are many, many, there's probably hundreds of different forms of dementia, but we often use that word as if it's an actual disease. And so I want to make sure everyone understands that that word dementia is just a general term. It's a generic term that describes a group of symptoms. It is not an actual disease. I frequently will talk to family members and I'll say, well, what was your family member diagnosed with? And they'll say, oh, they were diagnosed with dementia. Thank goodness it wasn't Alzheimer's. Well, maybe it was, maybe it wasn't. You know, there's a saying that all Alzheimer's is dementia, but not all dementia is Alzheimer's. And there are lots of different things that can cause those symptoms that we refer to generically as dementia. Lots of different underlying medical conditions, sleep apnea, medications oftentimes. We'll talk about these a little bit more in a minute. But please understand that diagnosing what's causing those symptoms that we refer to, again, I always use air quotes, as dementia, is a diagnosis of exclusion. And this is true in the general population and true for people with ID, especially for people with ID. Um, we want to rule out any potentially treatable conditions, of which there can be a lot, before we assume that the change we're seeing in a person is due to Alzheimer's disease or any of those other common irreversible forms of dementia, Lewy body being a very common one, vascular dementia, frontal temporal dementia. And really important to understand is that the diagnosis should never, ever, ever be made on the basis of just one office visit or just a simple cognitive screening test, such as the MMSE. It should always be done after a very thorough process and, you know, ruling out any potentially treatable conditions. And we're going to dive into that more in just a minute, but be aware because, and I make this point because what I see all the time in the population of people with IDD, and very frequently, unfortunately, in the general population, is that the family sees a change in the person and knows that something's not quite right. So they make an appointment and they go to the doctor's office. And based on maybe a cognitive screen, and when we refer to cognitive screens, such as the mini mental status exam, MMSE, those are those tests where you have to count back from 100 by sevens, draw the face of a clock and put the numbers in and draw the hands of the clock to the proper time that they tell you, those sorts of tests. And based on nothing more than that, the individual is told, well, you have dementia. Or if you're a person with ID, frequently people with Down syndrome, well, you know, you're 55 years old and you have Down syndrome, so it's Alzheimer's disease is starting. That should never, ever, ever be done. And we all have to be good advocates for our clients as well as our family members. So we're going to talk more about that as we go along. So let's talk about how dementia may come on or present a little bit differently in adults with ID than it does people with the general population. You're all adult day providers. So my assumption is that because you're providing adult day services, you probably have a history with people with dementia with people in the general population. So you've got a certain base level of knowledge already. But for people with IDD, there are some differences. And one of the first differences is how oftentimes these symptoms of air quotes dementia or Alzheimer's disease come on in this population. We spend a lot of time talking about people with Down syndrome, and people always say why. And the reason for that is people with Down syndrome have an increased risk of developing Alzheimer's, and they do so at a much younger age than the general population. The general population, generally speaking, 65 years or older. But in the Down syndrome population, it's usually much younger. And it could be from the age of 40 on up. Most people are diagnosed in their early 50s. But, you know, starting in the 40s, I think about 25% of people with Down syndrome, you get into the 50s, a larger percentage. By the time you get into the 60s, you know, even a much larger percentage. And that's because people with Down syndrome have an extra copy of chromosome 21. We all have two copies of it. Well, people with Down syndrome have an extra copy. They have three. It's called trisomy 21. And it is on this particular gene that the amyloid precursor protein is located. And this is one of the things that is thought to be responsible for Alzheimer's disease. And you've probably heard of the plaques and tangles of Alzheimer's disease. Well, it is, that amyloid precursor protein, which kind of starts this whole thing in motion. And in fact, if we were to do a scan of the brains of people with Down syndrome, we would find that even people with Down syndrome in their 30s, we see those plaques. So much younger than we would expect to see it in the general population, and that's because they have uh, that extra copy of that gene. There is a lot of thinking, and Down syndrome, out of all forms of ID, is the one we have studied the most in terms of dementia. And one reason for that is researchers hope to find insights into potentially ways to slow progression or prevent disease in all populations of people. And because it is, so prevalent at a younger age in people with Down syndrome, more has been researched in this population. Well, what about other forms of ID? People with autism, Williams syndrome, Fragile X, cerebral palsy. Hold that thought. We are going to talk about that in just a minute. But just be aware, if we do tend to focus on Down syndrome, it is because they tend to be the largest population of people with ID who develop Alzheimer's disease, although they could develop any other form of dementia as well. I've heard of a few people with Lewy body and Down syndrome, but generally speaking, Alzheimer's, and they do so at a much younger age. So, in the general population, the first thing we usually see that would be a signal to us that something has changed in this individual, maybe something needs to be evaluated, is short term memory loss. And that's what we saw with my dad. He started asking the same questions over and over again, as if he had never heard my response to those questions initially. And in fact, it wasn't that he forgot what I told him when he asked me a question, it was that that information never got encoded in his brain properly. And so every time he would ask the question, in his mind, he genuinely was asking it for the first time, in his mind anyway, even though it was, had asked me the same question multiple times in the course of half an hour or an hour. So normally that's one of the first things, not always, but by and large in the general population, that's one of the first symptoms we see. It's a little bit different in people with Down syndrome. Instead of that short-term memory loss, oftentimes what we see first is a change in personality. They may become more withdrawn. They may become more moody, maybe even see some aggressive behavior, may lose interest in activities or hobbies that they used to enjoy, potentially change in their sleep patterns. We might also see the onset of seizures. And this may be an individual who's never had seizures before, and now we're seeing new seizures. Or maybe they've had seizures when they were younger as a child, but they've been controlled for years, but now we're seeing them flare up again. Oftentimes, in people with Down syndrome, and a large percentage of individuals, that onset of that seizure activity can be a legitimate kind of red flag waving at you that you might be looking at the onset of Alzheimer's disease. You'd still want to do that differential diagnosis, rule out any other potentially treatable causes for it. But those seizures are kind of a hallmark of Alzheimer's in people with Down syndrome. And there's a myth that 100% of all people with Down syndrome are going to develop Alzheimer's disease. And that is a myth. But it's still out there and it's pretty prevalent. Not everyone with Down syndrome will develop the disease. I know last I heard there was someone in their 80s with Down syndrome who had not developed it. Definitely a large percentage will by the time most individuals with Down syndrome reach the age of 60. About 65% of them at age 60 will have Alzheimer's disease, but not all. However, they will show the brain pathology, those plaques and tangles, if we were to autopsy their brain, even though they might not show the outward symptoms of it. That's actually true in the general population as well. We know that There are a number of people in the general population, if we were to autopsy their brains after they die, we'd see those plaques and tangles characteristic of Alzheimer's disease, or the plaques characteristic of Alzheimer's disease, but they maybe never developed the symptoms. And we don't have a good answer for why that is yet. It just is. Um, but on average, most people with Down syndrome will develop Alzheimer's disease if they're going to in their 50s. I do need to tell you that if someone is younger than 30 years old with Down syndrome and they start showing signs like I listed above in that first bullet, um, under the age of 30, it is highly, highly, highly unlikely it is Alzheimer's disease. Alzheimer's disease is uncommon in someone with Down syndrome under the age of 40. But even under the age of 30, it's really, I mean, I guess you never want to say never. But most of the experts that I look to for these sort of answers would say that younger than 30, it's not Alzheimer's disease. It's this condition commonly called regression, more formally called Down syndrome disintegrative disorder. And the good news about that, if there is good news, is that it may be treatable. Figuring out if this change in this younger population of people with Down syndrome, we could be talking even children, teens, 20s, really that much younger population of people with Down syndrome. It can be a little tough to figure out. It's still a diagnosis of exclusion. You would still do a lot of the tests that I'm going to tell you about in a minute that you would do to rule out Alzheimer's disease. There has been some research. One of the physicians that we work very closely with at the NTG, Dr. Brian Chicoine from Illinois, he has found that in a number of his patients, that there seemed to be some sort of a really severe, stressful, traumatic life event that preceded this quote regression. We're also finding Dr. Jonathan Santoro out in California is now finding in some research he's doing that it could be an autoimmune issue. And so, not a lot of physicians who are experienced in this. On our NTG website, we have a page devoted to this topic. I invite you to look at that if you want more information. I'm going to put our website up at the very end on the last slide. But under the age of 30, it's not Alzheimer's disease. Someone told me not long ago, I know someone who was 19 years old and they had Alzheimer's disease. No, the odds are it was Down syndrome disintegrative disorder, not Alzheimer's. And again, may be able to be treated and restore that person to a baseline level of functioning if we can get the proper testing done and figure out what it is that's causing it. But what about other forms of ID? What do we know about them? I said we know the most about the Down syndrome population. Unfortunately, not a lot of research done in other forms of ID. When you think about autism and cerebral palsy and a host of other forms of ID, most of the research that's done is done in children. Very, 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 very little is done in older adults. And so we don't know a lot about the aging process generally in those other populations. We're learning more, but we don't know a whole lot. And we don't know a lot about the onset of dementia. We can draw some, some thoughts maybe, but we don't have a lot of good research to back them up. We do seem to think that the signs of dementia may vary by the level of ID. So someone with a more severe ID, the thinking is that you might see weight loss, loss of energy, sleep disorders as kind of a presenting symptom. For milder forms of ID, could be more anxiousness and worry, weight changes, and reduced ability to do some of those self-help skills that they were always able to do. We are going to have a future webinar, I believe, on something called the EDSD, which stands for the Early Detection Screen for Dementia. This is something that the NTG created about 12, 13 years ago, I guess. I'm going to touch on it in a minute, so kind of hold the thought. But this is one tool that could be useful to you, not just in people with Down syndrome, but also other forms of ID, to kind of pick up when you might be seeing a change in someone. So kind of hold that thought for just a minute. What do we know about people with autism and aging and their risk? Well, we know that the first group of people diagnosed with autism way back in the 1940s are now in their 70s and 80s. And, certainly research has told us that autism does impact some of the same regions that Alzheimer's disease does. But again, most of the research has been focused on children and adolescents. We really don't have a lot of research to point to. There is some being done, but it hasn't yielded a whole lot of meat for us at this point. Certainly, Alzheimer's shares some common features with autism, such as language impairment, executive function, sensory and motor problems. We could predict that those would get worse if that person develops Alzheimer's or another form of dementia. There have been some studies that say that brain plasticity in people with autism may protect them from, Alzheimer's or other forms of dementia. But there are also equal studies that say that certain forms of autism increase a person's risk of developing Alzheimer's. And I think there are other things as well. Certainly, there are people with autism who have been on antipsychotic medications for many years. Is that going to play a role? My personal opinion is that it might. But, I wish I could tell you more. We just don't have a clear understanding. We do know that people with autism may have higher rates of diabetes and heart disease, and those are known risk factor for Alzheimer's disease in the general population. So could that increase the risk in people with autism? It could. Again, polypharmacy, particularly those antipsychotic medications, could increase risk. And there have been some studies that have found higher rates of Parkinson's disease in people with autism. Parkinson's disease is related to Lewy body dementia. There's also a Parkinson's dementia. So could that, account for a higher rate of, Lewy body or Parkinson's dementia? It's possible, but I don't have any good answers for you because we don't have real research in that area yet. What about people with cerebral palsy and dementia? Again, not a lot of research there. One thing that, if there's anything kind of consistent that I have heard, is that if you see, as a person with cerebral palsy ages, and you see a change in their ability to function or their behaviors from their baseline, pain could be a reason for that. So if you see a change as they age, you would want to rule out conditions that could be painful. I went to a presentation recently at the American Academy of Developmental Medicine and Dentistry in June back in Chicago, and went to a presentation by a physician who was talking about aging and cerebral palsy, not specifically dementia, just general aging. And that was the key point she had, is that if you see a change as that person ages, look at pain as a cause for that. And untreated and undertreated pain is a huge issue in all forms of ID, particularly with people with more profound signs of ID or people who are nonverbal because they can't communicate that they're in pain. And as someone said in a meeting earlier this morning that I really loved, people for whom people are nonverbal, you have to listen with your eyes as well as your ears. Someone who's verbal may be able to tell us if they're in discomfort of some sort, but if they're not able to do that, then we have to use our eyes to look at their behavior. Behavior is a form of communication for people who are nonverbal. And so for folks with cerebral palsy, think about pain. Fragile X, again, is one that you might run into. There isn't any research that really indicates, at least at this point, a real increased risk of people with Fragile X developing Alzheimer's, although they could. But what we have found, and I think this is interesting, I've actually run into this a few times, is that if a family member has, if you have someone for whom one of their family members has Fragile X, it wouldn't be a bad idea for them to get tested, um, to see if, they carry this gene, which about 1 out of every 151 women and 1 in every 468 men carry. They may be at a higher risk, and this isn't a person with Fragile X. This is their family members that don't have Fragile X. Those family members may be at a higher risk of developing a dementia as they age, known as Fragile X associated tremor ataxia syndrome, FXTAS for short. Um, Usually occurs over the age of 50. And oftentimes it's initially misdiagnosed as Parkinson's disease, maybe Alzheimer's, or even a stroke. But what you see in these folks is sometimes sort of balance problems and tremors. And I have had a handful of people over the years who have uh, been evaluated for, in the general population, evaluated for some form of dementia. And then one of their presenting symptoms was tremors when they're reaching for something. And we wouldn't normally see that with Alzheimer's disease or some of the other more common forms of dementia. And so, in a couple of these cases, they actually did have a family member that had Fragile X. They might have some numbness in their extremities and so forth, in addition to the cognitive decline. So, kind of an interesting little, you know, side effect, I guess, of Fragile X. You also might once in a while run into someone with Williams syndrome. And for those folks, there's maybe a higher risk for vascular dementia because they oftentimes have cardiovascular issues such as hypertension. And so they could be at higher risk for developing that vascular dementia, which is caused by strokes or TIAs, transient ischemic attacks. You might also see some weight change in their appetite, the onset or an increase in physical aggression, and reduced speech quantity. So I have just now told you the sum total of what we know about dementia in Williams syndrome. And it's really sad that in all of these we've just talked about, I can't tell you more, but this really is about all that's out there in the literature. Sometimes people ask me about people with severe and persistent mental illness. Are they at a higher risk or lower risk? Again, we don't really know. To the extent they've been on antipsychotics for years and years could increase risk. Um, there's certainly some research that shows that there's a higher rate of cognitive impairment. Is it Alzheimer's disease, or could it be caused by medications? Don't have a good handle on that yet. But again, when you see individuals aging, whether they have ID or severe and persistent mental illness, don't make that leap that the change is due to Alzheimer's disease. But conversely, don't just assume that, it's that underlying mental illness or the underlying disability. This is called overshadowing. You want to do the due diligence to rule out any potentially treatable underlying medical conditions that could be causing the changes. And again, traumatic brain injury, we've heard a lot about this in the context of football players. And I've even heard recently about soccer players because they bounce the balls off their head periodically, and other sports as well. Also hear about this a lot in populations of veterans who've been exposed to IEDs, explosive devices in the Gulf War, and in Iraq. And so I think in this context about people who might have self-injurious behaviors who have IDD. And so there is certainly a link that shows there is an increased risk. And, again, maybe some of you who are my age remember years ago, boxers, it's called dementia pugilistica. And that was from those repeated blows to the head. And so that certainly could increase their risk for those chronic traumatic encephalopathies, which is a form of dementia. And so in this context, in the IDD population, I think about people who might have engaged in self-injurious behavior. Underlying medical conditions. What are some of those potentially treatable causes of that air quotes dementia? First and foremost, the big issue for people with IDD, we talk about diagnostic overshadowing. And so, what does that mean? I mentioned it a minute ago. It just means that when you have a symptom of some illness, there could be multiple things that are the cause of those symptoms. What we see happening for people with ID is that those symptoms either get kind of written off as their underlying disability. Oh, it's, their Down syndrome. Oh, it's their, you know, their Fragile X, it's their, it's autism or ASD, whatever. Um, or, and we don't do the due diligence to see what's going on with them. The other thing we see is people with IDD age is that, particularly people with Down syndrome, there's still that myth that 100% of people with Down syndrome will develop Alzheimer's disease. And I have seen more times than I care to count, um, caregiver for someone with Down syndrome who sees a change in the individual's ability to function and starts to become concerned what's going on with them. And they call the doctor, and the doctor says on nothing more than a phone call, literally, oh, they're in their 50s or their late 40s and they have Down syndrome, so it's the onset of Alzheimer's disease. That is wrong. I cannot say that often enough. Um, all sorts of things can cause those same symptoms that would lead you to think it was Alzheimer's disease. And certainly for people with IDD, although true in the general population too, um, there are a lot of those underlying medical conditions that people with IDD tend to have. Vision and hearing impairments. People with Down syndrome oftentimes have vision and hearing impairments. Those can cause changes in function. If you can't hear properly, if you can't see properly, you may not be functioning the same, and people might be tempted to think you're getting confused. And is it, dementia? People with Down syndrome, hypothyroidism is very, very common. And so you want to make sure that people are having regular blood tests to check their thyroid levels. Osteoarthritis, very common as people age, both in the general and IDD population. Interestingly, for people with Down syndrome, Dr. Chicoine, that I mentioned earlier, has found that when he sees a new patient and they're being brought into him for an evaluation because there's a thought that they might have the onset of Alzheimer's disease, one of the first things he does is test for celiac disease. And he's found in a fairly significant number of cases, the cause for those symptoms were celiac disease. It wasn't the onset of Alzheimer's, it was celiac. That's not something that the average physician is necessarily going to know or think to test for. So we need to know that. I always say when Kathy and I do workshops around the country, the intent isn't to teach you to be an expert on this. We just want to teach you enough so that you can be dangerous. And so understanding, that there are these other conditions that can cause those symptoms or those changes in functioning. There can be lots of potentially treatable causes for them. And we, as caregivers and as advocates, need to just know not to make a leap that, oh, this person has Down syndrome, it's Alzheimer's disease. We want to make sure that testing gets done to rule out any of these because they're very common. B12 deficiency, particularly in people with Down syndrome, very common. Vitamin D. Where do you get vitamin D? You get it from the sun. People with IDD don't necessarily spend a whole lot of time out in the sun like, we do. They could have a vitamin D deficiency, can cause these symptoms. Folate deficiencies, particularly if people have been taking antipsychotics long term, or if they have a seizure disorder. Some of the medications for seizure disorders can cause a folate deficiency. Sleep apnea, again, very common in people with Down syndrome. And over a period of time, that lack of oxygen overnight can cause those symptoms that we might be tempted to think was Alzheimer's disease. Lyme disease, if you live in a part of the country where there are deer ticks, and I'm doing this for Maine. I actually live in South Carolina. We have a lot of deer in South Carolina too, but I'm in Maine right now. I'm doing a workshop up here tomorrow. Um, and I lived in Maine for my whole adult life until I moved to South Carolina. There are a lot of deer ticks. And if you get bitten by a deer tick and you don't know it or whatever, it's entirely possible that could cause symptoms down the road, neurological symptoms that might lead you to think of Alzheimer's disease, when in fact it's Lyme disease. So you'd want to test for Lyme disease, anemia, infections, um, delirium. And I just want to call this out for a minute. If you see someone with a very sudden change, most forms of dementia come on very slowly and insidiously over a course of months and years. If you see a sudden change, that's not the onset of Alzheimer's disease. That is probably a condition called delirium, and that's a medical emergency. In other words, yesterday the person was their usual self, whatever that is for them. And today they're very agitated. They may be walking around with their fists clenched. Just something's really wrong. It could go the other way. Today, they don't even want to get out of bed. They just want to sleep. They don't want to eat. They don't want to do anything. So, one extreme or the other, and they can't fluctuate between the two. But a sudden change is probably this condition called delirium. It's a medical emergency. Most common causes are urinary tract infections. Many of you that have worked in long-term care have probably seen it with urinary tract infections. Second most common cause is impaction. And third most common cause is pneumonia and COVID rather. But that's not an exhaustive set of causes for delirium. It could be hundreds of other things. So if you see that sudden change, that's a medical emergency. And particularly for people with Down syndrome, interestingly, they need routine. People with Down syndrome get in what Dr. Chicoine refers to as the groove. They really like their consistent routine, and anything that changes that can be extremely stressful for them. And so that resulting stress and anxiety that it may cause, or depression that it may cause, can also cause symptoms that look a lot like Alzheimer's disease. And in fact, severe depression has been called pseudo dementia. And I have seen it many times in the general population. Someone who's severely depressed looked a lot like someone who had Alzheimer's disease. But when it was finally figured out they had depression and they got on the proper medication, those symptoms went away. So make sure that you never make that assumption that when you see a change in someone, that it's just due to Alzheimer's disease, particularly if it's someone with Down syndrome, because of that still very pervasive myth that 100% of people with Down syndrome will develop Alzheimer's. So, what tests should be done? Well, or what steps should be taken? First of all, you see someone, there's been a change in them. You're wondering, could this be the onset of dementia? Have they had any recent life changes or stresses? Could it be severe depression that's causing this? If the answer is no, do a medication review. A lot of people with ID have been on multiple medications, referred to as polypharmacy, for many, many, many years. And there's a particular class of medications called anticholinergics. They're very commonly prescribed medications. And if you take 2 or more of these particular medications, and do so for a very long period of time, that can cause cognitive decline. And again, they're very common. Antipsychotics are anticholinergics. If someone takes Benadryl at bedtime to make them drowsy to sleep, Benadryl is an anticholinergic. Detrol and Ditropan for overactive bladder are anticholinergics. There are a lot of them. You can do a search on Google, anticholinergics and dementia, and you will find all sorts of information on that, but a lot of very common medications. So you would want to make sure it's not a medication issue. Complete history and physical, and then blood tests. At a minimum, you'd want B12, folate, check the thyroid function, a CBC, complete blood count, to make sure the person didn't have, some sort of an infectious process going on. Oh, see another typo. Check their blood sugar levels, lipid profile, urinalysis, electrolytes, kidney and liver function, because if your kidney and liver isn't functioning properly, that can cause toxins to build up in your bloodstream. Lyme and celiac, as we mentioned. If someone's having seizures, an EEG could be useful. In the general population, we'd absolutely want to see an MRI or a CAT scan, or now we're seeing more PET scans. Not as commonly done in people with ID. Informed consent is necessary. They may need to be sedated, and you need a radiologist who is familiar with reading those neuroimaging results, who's familiar with people with IDD, because sometimes Their brains may look a little bit differently than those of people in the normal population, and you want to make sure that they are familiar with that. And in the general population, you'd certainly want to do, well, I won't say certainly, but you'd oftentimes see neuropsych testing done. I rarely see it done in the IDD population, but I don't want to say never because I've run into it a few times. There are a few neuropsych tests that might possibly be relevant for this population, um, but not as commonly done. Remember that Alzheimer's disease is always a diagnosis of exclusion, and you want to rule out any potentially treatable conditions before you arrive at that diagnosis that it's probably Alzheimer's disease. Whoop, there we go. And remember, this does not happen in one office visit, ever, ever, ever. What about medical management? Let's assume Alzheimer's disease has been diagnosed and that that's the correct diagnosis. What about medical management? Well, you've seen the ads on TV for Aricept. Namenda is another one. They've been around for a number of years. Oftentimes, Aricept and Namenda used together. Aricept for earlier stages of the disease, Namenda for the later stages, but again, oftentimes used together. Some thought it works a little bit better that way. The important thing to know is that those medications do not slow the progression of the disease. The disease is going to progress. What those medications do is increase the availability of an important neurotransmitter in the brain. Remember, your brain has all the brain cells. If you remember your basic biology from, I don't know, probably junior high or high school, and there's all these, nerve cells and these spaces between the nerve cells, and the signals have to go back and forth between those nerve cells. And what facilitates that is these neurotransmitters. And in Alzheimer's disease, because of these plaques and tangles that you see here in the picture, those cells die and communication between the cells is impaired. And so Aricept, Namenda, and there are others, Exelon and others, but Aricept being the best known, they may increase the availability of that neurotransmitter, which may help with symptoms for a little bit of time. They don't help forever, though. And relevant to the population of people we're talking with, there have not been any good studies that show that those medications are effective in people with Down syndrome specifically. So sometimes we see them prescribed, but no good evidence that they will be of any help for folks with Down syndrome. And there are some physicians who don't like to prescribe them for people with Down syndrome under the guise that all medications have side effects. So why would I want to prescribe a medication that we know has side effects and that also has no track record of providing a benefit? But we do see them prescribed. There's some new drugs that have recently been approved by the FDA. Leqembi is the trade name of one that you've probably seen. The most recent one is donanemab, Kisunla. I have trouble saying that word. Sounds like you're sneezing. And these are infusions. These are not pills. These are infusion therapy. They're a little controversial, a lot of media hype about them. They may slow the progression a little bit, but they're not going to stop the progression. These are not cures. And the important thing for our discussion today is that neither of these, and there was, Aduhelm before Leqembi, no clinical trials were conducted on people with Down syndrome or other forms of ID. And so we don't know how they would work for that population. We know there's some fairly significant side effects for these medications in terms of brain bleeds, microhemorrhages. We know that people with Down syndrome have a predisposition to those. And so is that going to be a problem if these medications were used in people with Down syndrome? It could be. There is some research being done in this area now to try and answer those questions. They're also very expensive, about $26,000 a year, although CMS has said they would pay for it. But you have to be very, very early stage, and the likelihood for, particularly I think for people with Down syndrome, of being found early enough in the process to benefit from these newly FDA approved medications is probably not very likely. But I put them out there just because you may hear those names. Non-pharmacologic management. I cannot say this strongly enough. Antipsychotics are always a last resort for managing behaviors. I think we're going to have a future session on behaviors, um, and we will talk about this in more detail. But antipsychotics should always be the last resort. There are many things you can do. First and foremost, in my mind, is caregiver education and training. Knowledge is power. And I cannot stress that enough. So, there are all sorts of online resources, YouTube videos, all sorts of things. And I think we are going to have a future session on this topic. So make sure you come back for that. Think about ways to reduce overstimulation. Overstimulation is the bugaboo for people with dementia, can be very upsetting for them. Try to keep stress and anxiety to a minimum by trying to keep to a routine as much as possible. COVID was very disruptive for all of us, but particularly for people with Down syndrome, because oftentimes the routine was disrupted. People who went to day programs or engaged in Special Olympics suddenly weren't able to do it anymore. And for many, that was very problematic, and we did see changes in behavior for people. Excuse me, that you might be tempted to think, well, is this the point they're developing Alzheimer's? And it was just that change in their, routine that was causing, stress and anxiety and depression, not Alzheimer's. Lots of things you can do to modify the physical environment to make it easier for people not just to navigate, but to decrease stress. Kathy Bishop, I believe, is going to be doing a session on that for you. That's her area of specialization. Mine is behavioral and psychiatric symptoms of dementia. Pain management. As I said earlier, pain, untreated and undertreated in this population, is a very real problem. And if you have someone who you know has a condition that can produce pain, maybe it's osteoarthritis, arthritis, whatever it is, and they're on PRN medications. There is a phrase in this field. PRN means as needed. You only take the medication when you need it. But for people who have trouble communicating their need, PRN stands for pain relief never, because they can't tell you when they need it. So make sure they're on a regularly scheduled dosage of whatever pain reliever they take. Reminiscence therapy is great. Validation therapy. Music therapy, fabulous. A lot of research on this in the general population. Anecdotally, works just as well for people with ID. And in fact, there was someone in Texas who did it in an ICF MR and found it was incredibly useful to reducing, some of the behaviors they were seeing on that unit. Sensory stimulation, and again, staff training. But we'll talk about these, I believe, in future sessions. And I'm going to give you a little tool here. Remember in the very beginning, we talked about mini mental status exam and so forth. You would see that used in the general population the first time you went to the doctor for change and function. That doesn't work very well for people with IDD, because the mini mental status exam, and there are others, but those tools assume a certain level of educational attainment. They assume a certain level of verbal ability. And a lot of folks with ID don't have those. If I've never been able to count backwards from 100 by sevens, asking me to do that is going to make me look more impaired than I am, because I was never able to do that. So you don't want to use those kind of tools that we would see in the general population. The NTG developed back in 2010 this tool called the Early Detection Screen for Dementia. This is not a diagnostic tool. You don't get to the end of this and have a score and it says, oh yes, this person has Alzheimer's disease or some other form of dementia. It's a screening tool, but I think you'll find it very helpful. We are going to talk about this more in a future session, so I'm just going to give you the Reader's Digest version of it today. But we would start using this tool for folks with Down syndrome at around the age of 40, non-Down syndrome in their early to mid 50s, but you could do it even earlier. There's no wrong time to start doing it. And what it does is it records suspected behavioral and functional changes in people with ID and kind of lets you establish a baseline for which you can then track changes in subsequent months and years. And ultimately, when you start seeing changes, it will sort of highlight areas that you would want to look further into. It's also good for having discussions and care planning between families and care providers. And oftentimes, we see community healthcare providers find it useful when they are examining them because they can look at it and very succinctly. It's a very visual tool. Can look at it and see exactly what's changed in this person. And the beauty of it is you don't need any special training to do it. Family members can do it. Staff at local agencies can do it. No clinical training at all necessary. It is available on the NTG's website. It is free. It is available in 9 different languages. There's a little manual that comes along with it that explains how to use it. So I'm not going to tell you how to use it today. And again, I think we're going to have more on this coming up. But I think you would find it a useful tool. So if you want to kind of dip your toe into the use of the EDSD, you can take your smartphone and scan that QR code there, or go to our website, www.the-ntg.org/ntg-EDSD, and you will get chapter and verse on the EDSD. You can download it from that site and find a lot more information there. And so I want to leave you with the thought that the NTG can be a great resource for you. We have all kinds of information on our website, on other forms of IDD. We've got quite a lot on aging and autism. Matt Janicki, who is one of our founders, kind of stores everything he comes across on our website. So if you're looking for information, I would invite you to check out our website. All sorts of good stuff on there that I think you might find helpful. And my email is down at the bottom. Please feel free to reach out to me at any point. I don't know if we have any questions, Kathy.
Yes, we've had a few. I tried to answer them,
Okay.
but can quickly at least one. One was about brain plasticity. What is it? I explained the ability of the brain to be flexible, to be able to adjust to learning and experiences. With disease process like Alzheimer's disease is impacted and the brain has less capacity. So that was one question. A question if the slides were going to be shared. I said yes, that it would be. And when you send out the recording. And there was another one who said that you mentioned irreversible dementia. Is there such a thing as reversible dementia? And I put in the chat that yes, things like dehydration, nutritional imbalances, depression, other things are possible, reversible, at least the symptoms, and reminded
again,
them
remember that word
dementia
dementia is not a disease. It just describes symptoms. So the question then is what's causing those symptoms? And there may be causes such as the things you just said that are, potentially treatable and can reverse those symptoms.
Yeah, and that's an extremely important question and answer. Remember, you always need to make sure that something isn't reversible. There also may be things that aren't irreversible, but are treatable. And so you need to think about the treatment.
Let's
And
see.
that's it.
And I see we had somebody asking about aging and individuals with autism. I actually have an individual, Kathy, that I was going to do one for the NTG, but we might want to maybe do it as part of this, so we can talk about that because he actually has some new research that was going to be coming out this fall.
Yeah.
And I am going to put up while we're just kind of finishing talking here, I'm going to launch that post-test poll again. And we're going to do this a little bit differently. Sorry. We're going to do this a little bit differently next month. Or yeah, I guess, no, when's our next session? Next month, right?
2 weeks.
No, 2 weeks.
2 weeks. Okay. Sorry. We're going to do it a little bit differently next time. And somebody mentioned that, you know, it's hard to do the test and listen while you're talking, and we appreciate that. So we're going to do it a little differently next time. But please help us out with our funders. You know, by doing the post test, you already now you know the answers to all these questions. If you had any questions about them before, so if you would just take a minute and re-enter your questions, your answers for that post test, we would be ever so grateful. And last words, Kathy and Phyllis, thanks for your attention. A lot of information in a very quick period of time. So I was talking fast. But if anyone has any other questions, don't hesitate to reach out to me. My email is there. I'm happy to answer them offline.
And Phyllis, do you want to introduce the next sessions or session coming up 2 weeks?
Okay, the next session is on the 21st of November, and it is IDD and dementia awareness, essential insights for day services staffs. We're hoping you can all join us for that. And again, if you have any ideas, things you'd like to hear about, please either put it in the chat. We'll be studying that, or send emails to either Kathy or me, Phyllis at OPICA.org. We'd love to get your input. And thank you for being here with us today.
And I'm going to leave this up
Thank
for
you.
a couple more minutes so people can continue with the post test. Kathy, anything else?
Just with the question about autism, I will be discussing autism within the context of environment and sensory issues, because I learned so much regarding dementia in persons with IDD and dementia in the general population, of how to adjust the environment from what I can learn from many people with autism.
So I'll leave this, I'll be sitting here in the background, and I will leave this up for a minute for those of you that are working on the poll. And when I see that you have, you know, completed, I don't see any more answers coming in, then I will close it down. But we really do appreciate your taking the time just to answer those questions for us. So
Catherine,
thanks. Yeah.
there is a question about how do you sign up for the next one? But if
Oh,
we've signed up for the series, then they'll
if you signed up for one, you are in for the whole thing.
Great.
So you'll be getting a link ahead of time like you did this time. But yes, if you signed up for one, you have signed up for everything. It was a little confusing. I understand the limitations of our registration system made it look a little bit more confusing than it needed to be. But yep, if you're here today, you are already signed up.
Thank you.
So take care, everyone. I'm going to leave this up for another few minutes just so everybody else can finish doing it. And we'll see you next time.
Thank you, everyone.
Thank you for coming.